Hello, and good afternoon, everyone, and welcome to the Health Insurance Innovation Series, where we bring developments from across the world to yourselves. My name's Conrad Kutz. I'm a health actuary with the Singapore Actuarial Society, and I'll be moderating today's session, which requires very little work from me. Today we have Faizan Shaikh he's the head of pricing of Zurich Middle East. He's been in employee benefits for 15 years, 10 years at AXA, where he was also the head of pricing before joining Zurich. And he'll be talking to us today around health developments in the Middle East. So just before I hand over to Faizan, just a couple housekeeping things. On your screens at the moment, you'll see a Slido QR code. Um, there's quite a lot of interesting information on today's presentation. So please use the Slido to post your questions. Please look at those questions and vote as well in case we're not able to get through all of them. Let's make sure we get through the most critical ones. Faizan has kindly offered to stay on the line for a little bit longer past 5 o'clock to answer any outstanding questions. We'll see how things look in about an hour. Yeah, so do scan this code. We'll put it on the chat as well, so you can just use the number and sign in yourselves. And then just for the next few innovation series sessions, we'll have the next session on Hong Kong critical illness products. You'll see an email blast going out about that later on over the course of this week. And also just a notice to keep the 10th of June lunchtime open. We have Ian Duncan, an adjunct professor from the University of California, coming to Singapore, and he'll be hosting a lunchtime session with the Actuarial Society, with the Health Committee Actuarial Society. So more details on that to go out in due course. Yeah, and I think with that, Faizan, we can kick off. So I'll hand over to you. Thanks very much.
Hi, Conrad. Hi, everyone. Thank you so much for inviting me to join your innovation session and to share the knowledge that I have of Gulf in this region. So I'll be doing basically, I'll be walking through some slides, and then we can obviously have some Q&A, and I'll be walking through some of the major product and innovation uh, that we have gone through in Gulf. But let's start the slides, and then I'll walk you through the entire project. Okay, let me know if you can see my screen.
Yeah, can see it okay.
Perfect. So this is the agenda that we will be covering. So first, I will probably walk you through some and give you some background about the Gulf health insurance landscape, because there are multiple countries present in Gulf, and then we'll be seeing exactly what they have and how does the overall healthcare market for insurance companies look like. And then we'll be going through some innovative products and benefits, where I'll be showing you some of the innovative products that we have had over the years and some which are launched recently and how do they look like. And then we will also look into the optimized utilization strategies, because over the years, as inflation keeps growing and as we face challenges in the healthcare cost, how exactly did the market tackle the utilization and the inflation itself. And then we will talk a little bit about digital transformation, because it has been one of the major projects in the region over the years. And although a lot of innovation is going around the world, and we can see that insurance has not always been in the forefront of it, but at the same time, I will share some ideas about what we are doing in this region. So let's start the discussion with the Gulf market. Now, when I say Gulf market, then these are the 5 countries that I'll be speaking about most of the time: UAE, Saudi Arabia, Oman, Bahrain, and Qatar. Uh, if I look at Gulf healthcare or Gulf insurance market, then UAE and KSA are the major countries. and Oman, Bahrain, Qatar are more developing towards having a better healthcare system. And I will show you some details about that. Okay, so let's first look at this. Now, what I'm trying to show here is if we look at each of the countries, number one is healthcare mandatory requirement or as insurance in each of the country or not. So in UAE and Saudi Arabia, yes, it is a mandatory requirement to have healthcare insurance by any national or expatriate living in the country. Bahrain, Oman, and Qatar, in those countries, it's not mandatory yet, and it is optional as of now. Now, if we look at the population composition of how it looks like, now what we can see, and I think that you can relate to Singapore to some extent in this perspective, that uh, in UAE, for example, only 10% of the population is UAE nationals, while 90% of the population is expatriates. In Saudi Arabia, again, although more than 50% are national, but there's a hefty portion of expatriates as well. Bahrain is half and half between expatriates and national. Oman also expatriates are more than 25% of the country, and that same concept applies to Qatar. From population point of view, I think, like I said, UAE and KSA are the major economies, and you can see it from even population perspective. There are more than 40 million or almost 50 million population is actually in UAE and KSA. But if we see the other countries, the population is small comparatively, but it's also growing because a lot of population is very young population as of now. Now, if we see the health insurance landscape, how exactly it works. If I talk about private sector, then private sector has only private medical insurance that they can go to because they don't have any option available in UAE and KSA both from the government. In public sector, uh, in UAE, for example, it is funded by the government. They pay for their health insurance of the public sector employees and members, and also it applies to KSA. But if I look at other countries, it's not exactly the same thing. In Bahrain, for example, or Oman, PMI is only available as an option for any private or government employees. On public sector, they are working towards developing a mandatory system. It's not there yet, and same goes for Oman. Qatar used to have for public sector and for their nationals coverage from the government, but it was stopped in 2015 due to high expenditure. So right now, only private medical insurance is available in Qatar. If we look at the overall premium comparing to the population of the country, what we can see here is we have 10 plus 10% growth year on year, but it is very much linked to the population as well. As we see the population growing over the years in the countries, we see the healthcare premiums also growing, and right now we are close to $45 billion in premiums, while total population is close to 58 million. Now, just to give a very high level idea of what exactly is who are the main players in the market and how it exactly looks like. So, what I've done here is I've tried to segment the market in three different segmentation: affluent segment, mass market, and discounted segment, to look at the customer base in the three main segments and then see how or who are the players in the market. Now, we will start first with UAE. Uh, in UAE, when it comes to affluent segment, although from membership point of view, it's quite small in size, but in premium, it's high because its IPMI is very expensive proposition. So premium wise, it is a heavier composition. Now, the three major players who are in affluent segment are the players mentioned here. However, the dominance in this segment is by Cigna because they are one of the top, or they're not only on global side one of the top players, but also in this region. While if we look at mass market, now some companies that I've mentioned here, they are right in the middle because they have dominance not in one but two segments. And those are these three major companies. These three major companies are all semi-government, and they are publicly listed as well in the UAE. Just to give you a very high level context, although there are many companies in UAE that I've mentioned here who are in different segments of members, but in total there are 63 insurance companies in the UAE. So that's a very high number of companies. If we look at the overall economy and we look at the overall membership, which is almost 11 million uh, people across the UAE, that's a large number of insurance companies. Now, if you look at Saudi Arabia, I've mentioned here Bupa twice because one is Bupa Global, which is basically for only IPMI solution, but then we have Bupa Arabia, which is which has dominance both in affluent and mass market segment. And this insurance company is owned by Bupa, also owned locally, which is I would say close to 50% stake by local entities and also by public. And Bupa Arabia is the largest health insurer in the region. They are the biggest, and their financials are listed on their website. You can have a look there, but it is one of or the most biggest healthcare insurance company and one of the biggest insurance company in general as well. And after that comes Tavunia, who is similar size of Bupa, but Tavunia is composite. They have all lines of business, so it's very different compared to Bupa, but they both are similar in size, and that's why they are the most dominant players in Saudi Arabia market. In Bahrain, we have the global companies that are mentioned here. They are very much similar in all the countries because they have the regional presence, and hence they are able to provide their services across GCC. Uh, and then you have GIG as one of the regional companies, which used to be AXA before. Again, they have presence in all the countries also. But the dominance in Bahrain is again by a local company of Bahrain, which is BNI. So one thing that you will notice is between mass market and discounted market, the dominance is most of the time by the local companies which are based from the country, and they always have more edge over the regional or global companies when it comes to having dominance. In Oman, NGI, same concept. It's a local company, and that's why they have dominance in both affluent and mass market, and the largest health insurance company for Oman. And in Qatar, we have Qatar Insurance Company, which is again the largest company, not only of Qatar, but also of GCC. They are similar size of Bupa when it comes to overall revenues. So this is an overall idea of how the market looks like. Obviously, if I look at membership count, affluent and mass market segments, membership is lower than discounted, but at the same time, discounted markets average premium is much lower than mass market or affluent segment. So that's a very high level idea of how Gulf landscape looks like. Now we will jump into innovative products and benefits, and we will deep dive into each of the initiatives that we have taken over the years in Gulf, starting off first with soft gatekeeping. So this was first tested in 2018, and the idea was simple that if a member for outpatient is visiting an outpatient specialist consultation, because how healthcare market works in UAE is that when you have private medical insurance, you can just walk into a hospital and you can see a specialist without prior approval. So that's how private medical insurance works in the UAE. So when a member is going to see a specialist for consultation, if, for example, they want to go, they will have a 20% co-insurance on that. So what soft gatekeeping brought into the picture was the member should first go and see a GP. And if the GP refers to the specialist, then the co-insurance is waived. But if you want to see the specialist directly yourself, you will have to pay co-insurance. So just to give you a high level idea, a GP consultation in UAE costs around $30, while the specialist can cost anywhere between $80 to $170, depending on what specialty you want to see. Now, why we call it soft gatekeeping is because the option is with the member. If the member wishes to see the specialist but pay 20%, that's up to the member. Maybe they can, maybe they can't. But over the years, although they started in 2018 with COVID-19, one of the key changes that happened was with teleconsultation coming into picture. a lot of members or a lot of insurance companies, they started to use and they promote teleconsultation as a gatekeeper for this for this type of options. And now the question is obviously a GP can always refer to the specialist. They don't always have to stop. So another initiative that came over the years was more value-based service from those teleconsultation vendors, because it's not about how many members are you managing in general, but how many members are you curtailing from going to see a specialist for what type of condition. So more detailed analysis of the data by insurers and teleconsultation vendors, and how that enabled insurance companies to make sure that they are paying to those vendors for every successful curtailment that they are able to do for acute conditions, for chronic disease management, and all those sort of things. But at the same time, when this thing started to get more and more famous among insurers and among many insurance or many corporate clients, uh, we started to see some deflation in the claims. And also, although we saw an overall increase in consultation, if you count um, teleconsultation data plus the provider data, but overall the severity of the claims started to reduce significantly, because a lot of teleconsultation claims were much lower at cost compared to the specialist. So we did see this as one of the key differentiator and one of the key drivers to reduce the cost and to start implementing in multiple clients. But some clients are using it, some clients are not, but it's tried and tested as one of the key and one of the important initiatives that we have done. The the next one is for it's basically related to now inpatient. Now, as we were discussing about the landscape of GCC, majority of the members are expatriates. And if we look at UAE expatriate profile, you will see that almost 40 to 45% of the expatriates in UAE are from Southeast Asian countries. Now, what exactly happens there is that if you have an inpatient treatment and you have a surgery, now most of the members who are basically blue collar workers or light blue collar workers, they are working in the UAE or Saudi Arabia uh, by living alone. Their families are based in their home countries. So what started to happen there was a lot of insurance companies, they started to implement a local plus home country treatment, because we started to understand how the cost is if you do an inpatient treatment in UAE or Saudi Arabia versus if you do that same treatment in Southeast Asian countries where their home country is. And we saw obviously the cost was less than 50% compared to the UAE. So it was no brainer that, okay, if we open the network from local to home country treatment, and then we start working with TPAs in those countries in order to also add into the provider network uh, major hospitals in those countries, then can we see attraction from the members? And we did see, because for the blue collar and light blue collar industry, it was no brainer, as their families are based in the home countries, and if they have an inpatient treatment, they prefer to go to their home country through direct billing, have their inpatient treatment, and stay with their family while they're having the treatment. While for let's say mid management or low to mid management of our clients, what we started to use their HR and discuss with them, how can we incentivize a member? Okay, some in some cases the insurers were paying for the flight. Your flight is covered if you go to your home country for treatment, and you get a cash benefit on top. Still, with all those extra incentives, the cost of treatment for inpatient, we found it to be cheaper while they go to their home countries, whether compared to having the treatment done in UAE or KSA. Although this is a very, I would say, it's a more GCC related topic or solution, but the crust of the matter is that we are talking about if the country where the member is based is too expensive for treatment, and there are other countries around within few hours of flight difference, and the cost is less than 50%, then why not create some network and some incentive for members to actually go there and get the treatment and come back. Unless there's a long-term care, then I understand. But uh, for regular inpatient surgeries, why not create a stronger network to actually do it in the country where the cost is much lower? So as a formula, it does work, and at least for the clients where they are very heavy on blue collar industry and where they have for their uh, junior to middle management, they were basically choosing this option, and we saw a very high traction of this innovation. The next model, this is something which is quite old, and it actually started around 2015. So it's more like a closed network model. And so insurers, they started to work with some provider groups, and with those provider groups, what they would find is they have a massive network across the country of many clinics and 3 or 4 major hospitals within the country as well, or within the city as well. So what they started to do was they create these HMO and closed network model, and there would be two modalities of this model. The first would be where I tie up with this group of hospital, and I say, okay, you know what? For all of my outpatient requirements, my my XYZ client, I'm gonna pass it to you, and you manage all the outpatient services, and I pay you fee per member for that client, and you manage it for the whole period of the contract. While in the second model, I would give not only for outpatient but also for inpatient, outpatient, end to end. You manage the you manage the client and the requirement of the client. Now, with that, obviously, what started to happen is that we, whenever you do it this way, then the provider themselves are able to use the economies of scale of having so many members and so much of footprint coming into them directly, and manage the cost accordingly based on the different mix of conditions that they are looking at. Uh, it's number one, it helps the insurer to understand that, okay, it's not fee for service anymore, and hence for all the different services I'm paying one fee to the provider, and the provider is the one managing the client's requirements. Most of the time, it was perfectly fine, and it did work well with the clients and they were happy. Sometimes there would be some issues because the the member care or the level of care is not exactly as per what the expectation is. But apart from that, one of the key challenges, because I've also worked on this, and one of the key challenges that I personally faced was, number one, the administration. The administration of this model is quite complex, because you have to have addition and deletion passing through every month, reconciliation with the provider on how much to pay them, how much to not pay them, and the monthly reconciliation cycles and all the process was quite difficult. And the other issue that we also faced was on the fraud based abuse side, because at the end you have to do an audit of the provider to understand if they did conduct at the right level, or they provided the best healthcare services to the member. So the audit part was also a little bit more difficult than expected. So there are pros and cons with each insurer. They may give you an answer differently. For some, maybe more pros than cons, but in this model, there were pros and cons on both sides. Uh, Conrad, do we have some questions now, or we continue and we do Q&A at the end?
Give me a second. Let me just have a quick look. Um, yeah, we've got a few questions coming through. I think we can maybe just take a quick break and then go through the questions now then.
Yeah.
The first one is, how is the profitability of individual health and EB products in the Gulf?
The profitability is really good on, I would say, if you see large corporate, SME, and individuals, individual products are actually the most profitable between the three product lines.
Okay, that's quite interesting. So, and these mandatory products that are in the Gulf, they launched in a recent time frame. Um, so I guess sort of you're because it's mandatory, maybe you're seeing less anti-selection than from a normal individual product as well. But are you seeing sort of claims go up quite dramatically in subsequent, like in the second year or third year, because like waiting periods expire or underwriting expires?
So I'll probably give a quick brief here. One is for individual products, all insurers they do medical underwriting. They have you have fill a full complete like application form, declare all the conditions because whatever you declare, then those are covered, and the conditions you don't declare they go into pre-existing gap. Uh, the challenge is that yes, now to answer your question, if they're not declaring conditions, it would park under like as an actuary or pricing actuaries. When we are looking at the data, we will see a big chunk of members who did not declare conditions, but you can now see it in the claims data. Yes, they actually went for these conditions and they were claiming, but it was rejected because the pre-existing is not covered in the first year. It's due to waiting period. Now in the second year, we would see normally between 20 to 25% jump in the claims, but we know it, and
Mm.
once we know it after the first year cycle, we will price it in.
Okay. So, and then when you say like these health products are reasonably profitable in the Gulf, um, do you have like a sense of margin, like profit margins for the insurers? Is it like 0 to 5% or 5 to 10 or 25%?
On individual side, I think profit margin, depending on, we probably have to see it by affluent, mass market, and discounted. I think that the discounted and mass market are probably running between 0 to 5%, but affluent would be running between 5 to 10.
Okay, okay, okay. And I mean, some of those insurers you mentioned, like, are they fully they focus only on health insurance products, and some of them do blends,
Yeah.
combinations. Okay, okay, thank you. Um, okay, the next question. Did you see any changes in medical inflation after the implementation of GP controls? And then also follow up, what is the usual medical inflation in the Gulf for inpatient and outpatient?
So I think we will cover some of these items in the next slides also, because there are multiple different uh, defense mechanisms that are in place in Gulf. But to answer the question in a very simple way, uh, after the GP, the co-patient waiver, soft gatekeeping was implemented, yes, we saw in that situation, we saw a massive drop in inflation. It became almost low single digit uh, after the implementation. And on the other side, uh, both outpatient and inpatient inflation is quite different. And later on, we will see why. But outpatient inflation would be higher between 5 to 10%, while inpatient would be 0 to 5%.
Yeah, it's amazing. Okay. Yeah, I'm looking forward to seeing this upcoming slides and further discussion on that. I'll bring it up after the slides have once we've come to the later slides. Um, ooh, okay, from personal experience, GP would always provide a specialist referral. Oh, so I guess this question relates to, people can go to GPs and they say, oh, I want to see a specialist, and the GPs will easily provide that specialist letter. And now, especially with teleconsults, maybe that would be easier. So I guess sort of a two-folded question is how do we how do you prevent people from referring to specialists too easily? But then also, how do you prevent them from under referring people that should be going to specialists?
So I think you need to find the right balance. You need to find that sweet spot in the middle because what a lot of insurance companies started doing was they started to implement this value-based service KPIs with the teleconsultation vendors, where fine, they will receive a payment for every successful GP consultation, and for an insurer, a successful GP consultation is that it did not get referred. While on the other side, it will be cross-referenced with the disease mix, because your ICD coding needs to be checked for what conditions they are referring and what conditions they are not. Some conditions you have to refer it. Let's say if you hire a teleconsultation vendor for chronic disease management, for a fact, after they have seen a specialist, they don't, for any of their refills, probably for the next 3 months, they don't need to see a specialist again. So that's where I think the chronic disease management from the teleconsultation provider comes into play, where insurer only approves monthly prescription for the medication. And after first month, if they are doing it properly, then they should not be going to specialists up till 3 months, uh, ideally. So then you have to see it as a mix of between the diseases and also how many successful GP consultations did they do, and do a cross reference. So it's more like a value based service model that insurers have started to implement with the vendors.
Okay. So instead of trying to manage the providers directly, the insurers are still quite actively involved in management of the risk, but it's moving to different providers that are able to interject maybe more effectively. And I guess sort of it goes similar topic on the provider, the way the provider takes the risk, the other product development you mentioned. I was
Yeah.
also wondering, uh, so hospital and healthcare providers aren't tradition, especially if they've been on fee for service, they're not necessarily structured to manage risk and determine what the cost should be, or if it's going too high or too low. And now suddenly the incentives, instead of over servicing, it goes to under servicing. So I can appreciate how there could be a lot of issues around that initial transition. Um, but do you find that sort of they building up the capacity and the skill sets and the infrastructure they need to manage those risks?
Yeah, so some of the providers, when they implemented such close networks, they have their own team can, who again leveraging the data that they've been collecting on all the patients that pass through them. They can understand how, and it's simple. Once you understand the frequency of visitation and frequency by disease mix, then severity is simple because it's one provider and they have their own price list. So they are able to determine how would the cost work. Now, with insurance companies, what they would do is they would actually have them contracted more like profit or loss sharing model, where at least they work with the insurer for the best interest of the member and the insurer at the same time, because otherwise they would not be able to work under inflationary environment and not understand how to control the cost. So like there were all these things that I mentioned, these can, they can act in between as administration challenges of the whole model, but at the same time, it did work. For each insurer, the answer would be different. Some would say that the administration of such model was so difficult that they decided to not work on this model at all. And some insurers will say, no, actually, we saw so much benefit that half of our portfolio was parked with two provider groups managing their
Okay.
population. Yeah.
Okay. And then just the last question before we continue. Did you see the trend of teleconsultation continue after COVID-19?
Yes, and we will see one slide on that where I'll be able to share a little bit more concrete numbers based on some surveys that were done. But yes, the numbers at COVID-19 went extremely high, and after that, the stickiness was not exactly as per the expectation, but it did not go down to pre-COVID levels. It stayed higher, but not at the same level of COVID, of course. Uh, but I think there is another part of this, which is there was a little bit more stickiness towards chronic disease management through teleconsultation, than acute condition. Acute condition did not exactly stick, but chronic disease management did, because for chronic patients, every month going to see a doctor in order to get prescription with all the busy schedule, teleconsultation was able to help a lot, because they were scheduling all the appointments, they were following up themselves, and I think it was good quality of teleconsultation provided by the vendors, plus the ease of having it helped in stickiness.
Okay, okay. There's one or two other questions that have come up, but I think in the interest of time, I think let's continue and then I'll keep them for the end. Thanks very much, Faizan.
Amazing. All right. So now we go into the cost optimization strategies, because this is one of the important things, because healthcare inflation is higher than your core inflation in every economy, wherever you look. And hence, it's very important to implement and find solutions that will control the inflation and control the cost for both payer and provider, and also the client at the end, because they are the ones paying for it. So this is one of the, I would say, major innovations that has happened in the last 10 years, which is DRGs. Okay, so DRG, in a very simple mechanism, it is um, it is a group, it is a group cost of an inpatient treatment when a member goes to the hospital, from the consultation with the specialist all the way to their discharge. So it is basically a full package cost for a certain condition when a member visits a hospital. Now, this was first implemented in Abu Dhabi, then it was implemented in Dubai, and by 2022, full UAE as a country for both public and private sector. Everyone, all insurers and all providers are now managing all inpatient treatments under this DRG framework. So how DRG works, I can quickly show you. So there's a base rate. Now, it took years for the regulator to actually analyze all the data of healthcare inpatient treatments across the country, and they created a base rate. Like, this is the base. It's basically an actuarial model based on the data. You have a base rate, and then you have a diagnosis group factor, which is based on, again, the data. It is set by the healthcare regulator itself. And then there is an insurer multiplier. Now, a provider, so let's say you have the most expensive provider may have a factor of 1.2, and the most cheapest provider may have a factor of zero point 0.5. So that is a negotiation between the insurer and the provider to set this factor. The next one is the severity. Now, these severity are the three modalities: high severity, medium, and low severity, based on the patient. How the patient comes in and goes through the surgery, this is set. The factors are set by the regulator, and the hospital chooses based on the condition of the member, whether the member is on high severity, medium, or low. And that, as a multiplicative model, it comes to the final cost. Now, hospital may charge extra based on the member's condition and everything that is being used, but it cannot exceed 10%. So if the final cost is $10,000, then it cannot be more than $1,000. So in this model, the base rate is set by regulator. The factors are set by regulator. Only the insurer multiplier is set between insurer and provider, and that's their own negotiation. But apart from that, nothing else is controlled by insurer or provider. It's a complete end-to-end set model, which was run for between, it was first discussed in 2019, and till end of 2021 it ran through a shadow billing process, where insurers were doing a shadow bill under this model versus fee for service model, and then it was compared. And all actuaries from all the insurance companies, me, like, I was myself involved in this, where we were analyzing it. The answer was everything needs to be within 5% difference. Like, all, if you run a DRG system versus fee for service, it should not be more than 5% different. First we were thinking that, okay, maybe that's the whole idea, but eventually what we understood is the idea is to control inflation at the end of the day. Because once this got implemented, now The base rate, because it's set by regulator only increases the base rate by actual core inflation in the country during the year. They don't change the base rate as per if provider says I need 10%. No, they will not change that. They will only change it by the core inflation that is observed in the country. And in last 2 years, it's only changed once by 5%. So with this coming into play, what really helped was controlled on inpatient side, and that's one of the main worries of an insurer, which is inpatient. Control the inflation for the insurer and also for the client at the end because they are the ones paying for it. Uh, One of the things that also started to obviously happen with this was that once we started to run this, and it made a lot of sense also and made it very easier for the insurers to also base their reserving on how they were seeing this data. Because if a member is going for an inpatient treatment, based on this model, from the beginning, the insurer has an idea of what the total cost will look like. And at the end, for them to create an outstanding claim or even to create their reserves, it was not a very difficult thing because at the end of the day, it can be plus minus 10%. It will not be very humongously uh, high or low compared to the actual number. Because if the a member is admitted under medium, but while during the course is shifted to high, that may cause a change. But then again, that is something that even insurer can go and audit. Why did it happen? What was the reason? And does it make sense or not based on the disease mix and the condition of the member? But end to end, the model is quite sophisticated, and we have seen that although when it was implemented, there was initially a little bit of inflation between one insurer to another because at the end, the model works on the overall claims data and overall claims analysis. It's quite possible that between two different types of cancer, maybe they're cross subsidizing. Now, one insurer received the cheaper one and the other one received the expensive one in one of the years, and that may happen. But overall, countrywide, it showed that the inflation was controlled on inpatient side for the country itself. Given that so it was so successful here now, KSA is also working for their own inpatient DRG implementation, which they are planning to launch in 2025. And now the regulator for UAE has started to work on DRGs for daycare. And in the pipeline, they have planned to launch something very similar for outpatient as well as a model. But we will see of how it will look like and what type of measures are they going to take over there. Uh, Now, this is another, I would say, for expensive critical illness and expensive inpatient conditions. Uh, what some of the reinsurers they have started to do is that for example, these medical conditions that I've mentioned here, what they will do is that they will create a giant umbrella for all their insurance companies, and they will provide across the region for these seven conditions a product where the insurance company will cede all the claims that they receive under these conditions back to the reinsurer, and reinsurer is able to work with their giant umbrella in the region and manage the cost. It it does have a lot of impact because for one insurance company, uh, if they have a small portfolio of healthcare and they get one claim under cancer or organ transplant or kidney failures. These are one of the common critical illnesses. So if they receive one or two claims, they will get impacted a lot more in the year compared to the reinsurer who can actually manage this risk on a much wider scale. And I think this is a practice which is quite common now across a lot of regions. Probably even in Singapore, you're seeing that it's coming into life more and more. But it has definitely caused an impact for a lot of smaller health insurance companies when they work with reinsurers in the region. Based on my knowledge, obviously they use these rating factors to price it. And the last time that I saw that the cost can be as low as $25 per person to $150 per person, depending on the area of coverage, the benefit limits, the network that they have. So last up till 2022 they actually did not change the price, but after that in 23 they applied a 10% inflation. So that at least tells you that, okay, if even in the beginning it was priced a little bit with a little bit more pessimistic assumptions, then over the years the costs remained the same, and now only one time inflation applied, which is still continuing for such framework. Now the next example, now I think this whole concept of vertical integration between how in UAE, I'll give one example where two major reinsurers and one major health insurer, they own their own TPS. Now, this is a very important step that has happened over the years. And now you can see that there is a whole ecosystem. You can't see this as something which is independent with DRG coming into play. Now, if you have an amazing system as DRG to control inpatient cost, the only missing variable there is the multiplier, which is between insurer and provider, a factor. So it does make sense for the reinsurers to have that strong negotiation power to have their own TPA. If you have your own TPA and you can consolidate multiple insurance companies under one umbrella, working with that TPA, which you also own, then you can negotiate a better factor with the provider in order to control the inflation. And the same concept goes to the previous model that I discussed in the innovation, which was on soft gatekeeping. What if you have a lot of major clients and you're working with a teleconsultation provider? How can you make sure that the level of service is at par or at the best quality that they can deliver? Is by actually having your own TPA and having a division which can actually provide that. So, and that is what's driven this whole vertical integration, because it makes sense. And with this coming into play over the years, what's happened also on the provider side is very, very small clinics and providers, they were not able to survive because their own cost of running a small operation was way too high compared to their negotiated factors, because they had no other option. So all small providers, they started to merge. They started to merge together into forming to create their own economies of scale and to make it sustainable for them to uh, also control their own inflation and their cost and work side by side with these TPAs and health insurance companies. So this is a model, I would say, probably with all the changing environment that is going around, it's taken probably 10 years, but it exists. And there are different sorts of vertical integration in across the region. In UAE, I gave you example of this, where reinsurer and one health insurer owns their TPA. But in Saudi Arabia, one health insurer actually owns their primary care facilities. They have their own clinics which are available for the members, and when they create their own closed network, it's only funneled through their primary care facilities or their pharmacies. So it's different sort of vertical integration models, but it works if there is an ecosystem around it. And yes, we have seen that ecosystem is now created here for reinsurers and health insurers to create this sort of model and control the inflation and cost and provide the best quality of service. Okay, before we jump into the next topic, Conrad, any questions around the
Uh,
three slides that you want to?
yeah, there's quite a lot of interest in the DRGs. We've probably got 10 minutes left of the formal session. Um, shall
Should I spend maybe 2 minutes in the next slides or 3 minutes, and then we
Yeah, I
jump
think
straight to
so. I
Q&A?
think that would be
Yeah,
great. Yeah, let's do that.
yeah. So let's talk about telemedicine, because we have discussed it so many times now, and there were questions around it as well. Now we can just see that even since COVID-19, we are looking at very recent in the last 2 years, the data of how telemedicine is still being used. Now, teleconsultation in Saudi Arabia is much more popular than UAE, but it's still used. Online pharmacy is very famous because you have delivery at your home, so a lot of people are using it for that, and also the conditions management, which is very similar as well. So it is something that is being used across multiple specialities. Around 20% of the consultations are managed right now by teleconsultation, and 30% of the chronic diseases as well. So it's something that is definitely picked up. The stickiness is not as much as we expected, but is still there. The next one is really all the innovations and all the things we discussed. Everything is because of well reconciled and clean data. So all the direct billing data now in the UAE, we launched e-claim system in Dubai, Shafafia in Abu Dhabi in 2021, the national program in Saudi in 2022, and the Mani for Oman in 2025. You cannot create DRGs, or you cannot create a perfect end-to-end system without having the streamlined data. And at the end, the it helps the regulator to monitor that all the payments are going on time to the provider. And if there is a complaint from the member, they can just pick up the data and understand what exactly happened there and manage the complaint of the member directly. So it really helps across provider, regulator, and payer to to understand and to be very transparent with each other when it comes to this. Okay, so Conrad, over to you.
Thank you. Thank you, Faizan. Very relevant and interesting presentation. I think there's sort of a lot of commonalities with Singapore, but obviously a different environment, different market, and there are some differences. But I think it's been great. I'll get through to the questions in a minute. Just for those that joined a bit later, there will be an email this week about the next session we're having on Hong Kong, and to keep the 10th of June open, where we are going to have an afternoon physical session with Ian Duncan from the University of California. Okay, to the questions. Here we go. Okay, did providers end up coding using more expensive DRGs so that they could charge more? So yeah, upcoding.
So yes, obviously, whenever you have such mechanisms, there will always be fraud based on abuse, and that's why every insurer, they should have their own department for this. Yes, they were doing it, and the fraud based on abuses job was really to identify those. The good thing was, because everything was so transparent, that such cases, when it was the time for reconciliation, because insurer would approve based on the full situation the medium DRG, and if they want to change to high DRG, insurer will reject and they will only pay for medium. And at the time of reconciliation, with regulators' involvement, it would become a negotiation, and that's where they would work with the provider to find the right reasons. And if it's justified, of course, provider can receive it. But there was back and forth between provider and insurer in this situation.
Thank you. Okay, next question is, what happens when there's a new drug or surgical method that becomes available, but the cost exceeds the base rate? How often and how frequently is that base rate revised? Yeah, or when is it revised?
So if we go back, sorry, I will just go here so it's simpler. Now, this is the diagnosis factor. Now, if a new disease or a new treatment for a disease comes into play, then regulator changes this. Based on the new data, they will actually change the factor here. Now, it may not reflect 100% of the cost of that treatment, but that is where this one comes into play, because they can always get the 10% higher by using the justification that the factor is not fully justified for a certain medical condition or a certain treatment. For example, stem cell. It's one of the most expensive treatments that is happening around, and it's not exactly, I would say, DRG friendly. But then again, some of those would be even outside the coverage, so it can be treated uh, as a different case on fee for service situation. So DRG, I remember DRG was working on almost 96% of inpatient, but 4% was still outside the DRG scope. It would be parked in the other system because of its own complication or uh, probably the coding, which is not even relevant for DRG. And for me, one of the example was the stem cell
Yeah, like those gene therapy drugs
gene
are, yeah,
therapies. Yeah.
they're going to be just crazy. Okay, makes sense. Um, uh, Next question. How many DRGs are there? Base rate is the base rate, is it a range or is it a specific number? And does
Specific
it
number.
include the total bill? It includes hospitalization, surgeon, medication, like it includes everything, right?
So it's one number and it's a full package price. Package means from the entry of the member to the exit of the member and at discharge. So consumables, drugs, consultation, hospital stay. Uh, if there is even someone staying with the member because of the if member is young, so everything is part of this whole package price.
Um, Yeah, I see Mr. Chi saying maybe we should send the questions out for you and then we can send them out to the group, the answers to the group, maybe a bit after. We can answer in the writing. Yeah, thanks, Mr. Chi. I think we can definitely do that. Maybe we've got time for one more before people knock off. Um, did the private providers resist moving to DRGs? How did the market how was the market able to affect this change and have provider profits reduced since DRGs came into effect?
So I don't think anyone had an option of not moving into DRG. Both provider and payer, they had to move because it was implemented by health regulator. So if you have a product registered with the health department of health, you have to be on DRG or you remove your product. So there was no option. uh, for provider, I think with and there are it's not only DRG, because when DRG came into play, it did impact providers because now they don't have that much room to negotiate on inpatient side. So obviously they started to be a little bit more abusive, I would say, on outpatient side in order to cover their cost. And fraud, waste, and abuse was again on their toes from insurance side. But very smaller providers, they had no other option because of this situation. They started to merge into making a more sustainable environment for them, because otherwise very small providers won't be able to survive this. And there was closure of some very small providers.
Okay.
Major
Well, that
providers were
sounds,
able to manage.
yeah, that sounds like I mean, that's quite a big impact on the providers for the inpatient to be managed. And then, okay, now it's come up somewhere else and now trying to manage that. But it sounds like progress, which is positive. Um, Yeah, I think maybe just in the interest of time, I think the other questions can maybe be answered pretty quickly, but just I think yeah, maybe let's take that offline and then we can sort of just write back to those if you're okay with that, Faizan, if you're willing to. But yeah, I think with that we can end it there. Thank you very much for joining us, Faizan. It's been a great session, and thank you everyone for joining and listening and for your questions and votes.
Thank you. Thank you, Faizan.
Thank you, everyone.
And thank you, Conrad. Thank you.
Thank you. Bye.
Bye bye.
Thanks, Faizan. Thanks very much.